Hello, my name is Dr. Payal Kohli. I'm a general and preventive cardiologist based in Denver, Colorado, and it is my pleasure today to be talking to you about cardiovascular risk reduction in 2025. What precision tools do we have available to us? What are our prevention strategies? And where is the future of cardiovascular prevention headed? So I'm going to tell you a little bit about myself, and then I'll be delighted to introduce you to our esteemed panel. As I said, I'm a general and preventive cardiologist based in Denver, Colorado. I graduated from MIT, from Harvard, and from Brigham and Women's Hospital. I did my cardiology fellowship from UCSF. I'm founder and medical director of Cherry Creek Heart in Aurora, Colorado. I'm an associate adjunct professor of cardiology at Duke University and Johns Hopkins University. And one of the things that I love to do is to be an on-air medical expert for television, because it allows me to bring education to our patients, to the patient's bedside. I also have my own podcast called Heart of Medicine and a video podcast called Conversations with Dr. Kohli. So enough about me. It is my pleasure to introduce you to our privileged panel. I'm going to start with Dr. Deepak Bhatt. He is one of my favorite mentors and one of my long-standing role models in cardiology. He's also a director of the Mount Sinai Fuster Heart Hospital and the Dr. Valentin Fuster Professor of Cardiovascular Medicine at the Icahn School of Medicine at Mount Sinai. He also trained at MIT, Cornell, Harvard, Oxford, University of Pennsylvania, and the Cleveland Clinic, where he also served in multiple leadership roles before holding senior positions at the VA Boston Healthcare System and the Brigham and Women's Hospital. Dr. Bhatt is a globally recognized clinical trialist, a mentor like mine, an educator, and has more than 2,000 publications, numerous major awards, and leadership roles across the American Heart Association, the American College of Cardiology, the National Lipid Association, SCAI, and multiple flagship journals. He has led or co-led many landmark trials that have changed the landscape of preventive cardiology, including Charisma, Crescendo, Reduce It, Soloist, and Scored. And he currently serves on the board of directors and as the president of the AHA New York City chapter. Welcome, Dr. Bhatt. What an honor it is to have you here.
Really great to be with you today.
Next, I would love to introduce you to Dr. Joel Kahn, who's a practicing cardiologist in Detroit and a clinical professor of medicine at Wayne State University. He's triple boarded in internal medicine, cardiovascular medicine, and interventional cardiology, and he's also known as America's Heart Healthy Doc. Dr. Kahn founded the Kahn Center for Cardiac Longevity and has authored numerous academic publications and 6 books on heart health. He's a frequent media contributor and leads the annual Reversing Heart Disease Naturally online summit. Joel Kahn, what a pleasure it is to have you here. And finally, last but not least, my good friend and colleague, who is British, Dr. Dharmesh Patel. He trained at Guy's and King's College Hospital Medical School and at the University of London, and he's a faculty member at the Stern Cardiovascular Foundation in Memphis. He directs both the Stern Cardiovascular Lipid Center and the Cardiac Rehabilitation at Baptist DeSoto Hospital and serves as governor-elect for the Mississippi American College of Cardiology chapter. Dr. Patel holds 7 board certifications, including in clinical lipidology and hypertension, and sits on leadership boards for the National Lipid Association and the American Society of Preventive Cardiology. He's also a clinical professor of cardiology and currently serves as president of the Partnership to Advance Cardiovascular Health. Welcome, Dr. Patel.
Oh, thank you very much.
So as you've heard, our panel is incredibly accomplished and incredibly esteemed, and you're in for a treat today. But before we get started, I'd really like to set the stage for what we're talking about today. And as you all know, atherosclerotic cardiovascular disease continues to be perhaps the biggest challenge facing clinicians and facing medicine, not just today, but for the past several decades. It's the #1 killer of men and women in the US and worldwide. And every 40 seconds here in the United States, somebody has a myocardial infarction. And yet, despite seemingly having the formula for preventing atherosclerotic cardiovascular disease, we continue to face this type of morbidity and mortality. So the nice thing about being a clinician in 2025 is that we have many tools in our toolbox to not just assess our patient's risk, but also to think about how to modify it. And perhaps we have many more tools coming. But one thing that really has me a little bit scratching my head is how do we tell our patients about their risk? How do we communicate risk to our patients? Because it's such an abstract concept. And is the pooled cohort estimator, which is that equation that estimates, 10-year risk of ASCVD and a lifetime risk, really our best tool? So what we're going to get into today is really explore what tools we have in our toolbox today, clinical tools, biomarker tools, imaging tools, and then talk a little bit about what's coming on the horizon and also what the pharmacologic interventions we can implement in our patients. So before we get started, I'm going to open it up to the panel with a provocative question. And I want you all to answer this and tell me what you think is the most exciting shift that you have seen recently in cardiovascular risk assessment or risk prevention. Any takers?
I'll jump right on in. I spent 25 years in the cath lab, trained with Jeffrey Hartzler at Mid-America Heart Institute, stented, ballooned. Everything was based on eyeball assessment. And then, of course, 15 years ago came coronary CT angiography, which at William Beaumont Hospital, Royal Oak, Michigan, where I'm on staff, we embraced in the emergency room. If you had chest pain, you got a CCTA. And if you were clean, you got out of the emergency room in a couple hours. It was a great protocol. Still all eyeball medicine. So to answer your question, I think the AI plaque composition software analysis of coronary CT angiography with FFR by CT, which we've had for a while now, there's a couple different options for that, is the most exciting thing we've had. We've practiced cardiology since Mason Sones accidentally did a coronary angiogram, all by subjective assessment of coronary lesions. And there's so much inter-observer variability, including studies in the last 12 months, not just studies in the 1970s by pioneers. So I am just loving the ability to tell a patient exactly their total plaque volume, their non-calcified plaque volume, their calcified plaque volume, and stenosis impact, and using that as a teaching platform. Of course, it's a big test, it's an expensive test. Not everybody qualifies. And I find it by far the most dramatic motivation to get them lifestyle oriented and, compliant with the rest of the program.
Joel, you're making such a good point. And what strikes me is that, heart disease is such a big burden. And yet when we think about predicting our patient's heart disease, we don't look for disease. We look for sometimes predictors of disease. Whereas when we look for breast cancer, we do mammograms. When we look for colon cancer, we do colonoscopy. So I agree with you. Coronary CT angiogram as a preventive cardiologist has really opened up the world for me as well. And I'm using it much more than I've ever used before.
Me too. And just to keep it academic, there was a presentation in the American Heart Association over the weekend by James Min and his colleagues that compared to calcium scoring and many other measures, the AI plaque composition determinants were the most predictive of future coronary events. So, the database is building. It always needs to be better, but it's pretty good now.
What we're talking about is not just how much the blockage is, but how it looks and how it behaves, which I think adds so much information. Deepak, what are your thoughts?
Don't you hate when someone asks a great question and then the person that goes before you gives the answer that you were just about to give? So that's exactly what I was going to say. But, maybe I'll just put some other thoughts around it. So I do think in terms of risk prediction, the most exciting thing out there really is the ability to look at plaque and characterize it comprehensively in terms of what its constituents are, in terms of plaque composition, whether there's an effect on ischemia and so forth. For people that are having chest pain, it's in the guidelines. I was actually a member of that guideline writing committee. So there it's pretty easy. You have chest pain, it's one of the options. Sure, if you like to do stress tests, that's still okay. But if you want to actually get the anatomy and potentially also take a look at flow and plaque characteristics, it's one-stop shopping there. Now, for what you asked, though, prevention, that's a little bit different. I mean, I think there's intuitive appeal there, but one has to concede there isn't prospective randomized evidence supporting it. And at least, where I'm in New York City, insurers don't pay for it if you're using it for primary prevention. That doesn't mean that there aren't patients that come in wanting it, demanding it, willing and able to pay for it out of pocket. But that doesn't still mean that it's okay, because potentially it's going to lead to downstream testing that we all end up paying for. That is, even if someone pays for their CT angio just because they want to take a look out of their own pocket, if there's a severe lesion, if somebody says, oh, now we need to do another test, exercise stress test, or maybe even an invasive angiogram, which in an asymptomatic person you always want to think carefully about. But there could be downstream testing and even downstream invasive procedures, potentially complications. So, it really does require, I think, randomized data. And in fact, that's what we're doing in the Transform trial, taking primary prevention patients and randomizing them to intensive medical therapy based on the presence or absence of plaque versus just standard of care based on primary prevention guidelines. And that's going to be a few years before that 7,500 patient trial is done. Though we're up to about 3,000 or so randomized, but still it's going to take a while. So I would say to be a little bit cautious until trials like that and Scott Hart 2 and other ones come out that show whether that strategy actually is effective at, first of all, just predicting risk better than current tools like risk scores. Intuitively, I would think it would be, but nice to prove that. Second, to see if it prevents plaque progression as we're testing there. But third, and perhaps this is an aspirational goal, but ultimately the holy grail, I think, of all of these sorts of endeavors, does it actually prevent ischemic outcomes, a strategy based on using CT angio? Because, you mentioned mammography. Again, it's intuitive. Why shouldn't we screen for something that kills more people than, say, breast cancer or colon cancer? We're screening, or even lung CTs in smokers. There's guidelines supporting screening for cancer there. There's randomized evidence supporting it. But until we have those things for CT angio in the primary prevention work, I'd say maybe best to be a bit cautious.
I think that was a great summary. And I think, I'm optimistic that many of these trials don't just show us, of course, how much plaque we have and that, we can change clinical outcomes, but perhaps even impact human behavior. Because I do believe that's been one of the biggest challenges, as well as how do we get clinicians to intensify lipid lowering therapy? How do we get clinicians even to check the LDL? And so certainly the hope is that seeing the plaque might help inspire change, not just in the patients, but in the clinicians as well.
Yeah, well, Stanford did show that, in the Notify trial, it was published in Circ, really modest-sized study, but a great proof of concept that letting patients know that, there's coronary calcium, and their primary care physicians actually did motivate appropriate prescription of statins. So that's at least some evidence that if the patient sees plaque, if the primary care physician knows their plaque there, it can motivate appropriate change in terms of prescription of and adherence to statins. But again, it really need to do it on a larger scale and see if it impacts outcomes, if it's cost effective, a lot of things to check out.
And I think philosophically, it makes that risk more palpable when you see that plaque, and that's really what we talk about. How do we quantify this risk for our patients? Dharmesh, what are your thoughts?
Yeah, I think, as Dr. Butter said, the holy grail is really the outcomes. We agree with the fact that, these markers, these imaging tools are extremely important. As has been said, cholesterol has no voice. This is why 40% of people feel great the day before they die. But I do feel that these are very, very useful adjuncts to further personalize therapy. At the end of the day, Paul, these are tools, right? We are talking about scores and polygenic risk scores. These are populations, but when you're in the clinic with that patient in the room, it's you treating one patient at a time. So we really have to individualize the therapy depending on the patient. And as my colleagues have said, yes, with imaging, we now have amazing tools to maybe help further risk stratify us. So I think it's really important. But one thing that we didn't touch on was at the end of the day, when we do find these high-risk patients, what are we going to do? What excites me is that in the last 10 or 15 years, how LDL lowering has become so powerful and effective. In fact, here we are 10 years ago talking about therapies like PCSK9s, where the LDL therapy is now reduced 63%. And now with all these other therapies that we'll talk about later that actually help reduce cholesterol and help reduce risk. And let's not forget one thing. When you're seeing that patient in the room, LDL reduction is more impactful than obesity treatment or diabetes treatment in those patients in predicting further events. So I feel that the exciting area of medicine for me is reducing the LDL and the different tools that we do have now to treat that.
It's such an important point. And LDL first, LDL always, LDL cholesterol years of exposure has become this paradigm now that really people understand this endotoxin just like we think about smoking. So I get to go last, and thankfully nobody stole my answer. So I'm going to build a little bit on what Dharmesh said, which is, of course, we have the LDL pathway, but what I've been really excited about, both in terms of risk assessment, but also prevention, is really thinking about the entire patient, thinking about the cardiovascular kidney metabolic syndrome and all those parallel pathways of risks, LDL, but now we've got lipoprotein A, for which we may have therapeutics next year. We don't yet have outcomes data, but we certainly know they reduce LPA, but whether that reduces events remains to be seen. We've certainly got the obesity pathway of risk, and whether or not that's mediated by inflammation or those are two separate things, that is a pathway that we have targeted with GLP-1 receptor agonists and shown some benefit in. We've got our chronic kidney disease pathway of risk as well. We've got our triglycerides pathway of risk, where the triglycerides serve as a biomarker for risk, and Dr. Deepak Bhatt has published the REDUCE trial that shows that targeting that pathway can be helpful. And then, of course, we have, the thrombosis pathway. Dr. Bhatt has also published data on that through the COMPASS trial and others that shows that that's a pathway. So now we've got pathways at every step of the pathogenesis of the plaque, all the way from the LDL, the lipo-A, the inflammation, the propagation of the plaque, even to the rupture. So many things that we can target and things we can do. So really a wonderful time to be a clinician, like I said.